We have a special treat. Dr. Bourbon has got a couple of case presentations for us to finish out our second day of the meeting.
Crashing entrance. So yeah, thanks for the opportunity to participate here. And Lionel, just let me know how far you want to go till 3 o'clock, or why don't you guys just do a cut sign? Because I've got talks that'll take us through dinner. Right?
Let's shoot for 2:20.
Give me the cut sign when you're ready. But what I put together just over lunch here was something I thought would fit well. Is this idea from transitioning to the adolescent and the adult. And I think what's really special about this course is the audience that's diminishing and actively leaving right now, which I'm trying not to take personally. But having said that, the fact that we're bringing together silos that oftentimes aren't together, and the idea of learning from each other. So Chris pointed out ortho-neuro collaborations, pedi-adult collaborations, and the subset of us who have had experience in both, I think we learn and gain from that experience. So one of the big questions that I face often is when to operate in adolescence. Barry told us yesterday that the complication rates are much lower in adolescence, and it's much easier to do surgery to recover faster. But it really requires some information about the natural history, about what the symptoms are, and when should we observe something into adulthood. So when should the type 1A curve in a 17-year-old be left alone? Because how often do we see a symptomatic thoracic deformity in an adult? We really don't see that, right? So when do we leave things alone? And one of my mentors who I speak of often is John Hall, and some of you know of John Hall. He was at Boston Children's Hospital. He's a Canadian, and I tell Shane often how much I dislike the Canadians. He's not here, but there are a few I like, including Shane and John Hall. And John Hall used to say John Hall was a surgeon who actually was probably the best foot and ankle surgeon and the best hip surgeon and the best knee surgeon and the best spine surgeon at Children's Hospital. And he used to say, the decision of whether or not to operate is far more important than actually how to do the surgery. I mean, he was one of the only people who could say this because he's such a great surgeon. But the decision of whether or not to operate, he said, I could teach a monkey how to put in a pedicle screw, but whether or not to do the surgery is important. And Chris kind of covered this, the spectrum of things we see in the pediatric population. Well, which of these things are problematic in the adult? And sometimes, unless you see the spectrum of ages, you don't know which things have a natural history that's problematic. So what I want to do is make this interactive because Lionel and Kyle and Lee told me to do case presentations. So I'm going to present a series of cases. And what I want to do is ask, would you operate on this now? And some of them are pretty straightforward. And some of them I think might indicate some controversy. So for example, congenital scoliosis cases, we know about the natural history there, neuromuscular type things, syndromic, this is neurofibromatosis. This case, again, your 1AN deformity in a 17-year-old, right? Would you operate in this? So I'm going to give specific examples. Tomorrow, I'm going to talk about spondylolisthesis. So I'm going to cut that out. And Sherman's kyphosis. So the point being that I think where there's controversy, and these are the cases I'll focus on, spondylolisthesis, and I think I get 20 minutes on that tomorrow. So I didn't do any spondylolisthesis cases here. You'll hear enough about that tomorrow. Developmental kyphosis, I think that's a really interesting example, right? So our Sherman's cases, when do we operate on a Sherman's case? I'll give you a couple examples. In our late onset AIS cases, right? We heard a really nice talk yesterday, a couple of nice talks yesterday about early onset scoliosis, but very different. What about the late onset scoliosis? And what I'm going to suggest is maybe some of these thoracic curves we leave alone, whereas I think some of the lumbar curves maybe we're better off taking care of. So let's go ahead and do some cases and make this interactive. Here's a boy, he's 17 years old. He's actually a rower, active in sports, relatively flexible, thoracolumbar deformity. And he says, I'm not really bothered by it. I swim, I row, I'm very active, I don't know much pain. But his mother says, gosh, he's so round-backed and his mother's really sort of driving this more than he is. 85-degree curve when he's standing, pretty flexible. This is him bending over a belt bolster, gets down to about 50 degrees. Is this somebody we operate on, or is this somebody, maybe I'll start with Baron. How do you think about somebody with this presentation?
I'd kick mom out of the exam room, but I think that's actually really important. So we had a prospective and retrospective study on this population. So I've learned a lot. We have about 10 or 11 publications in this, so we learned a ton. And when you compare the Scheuermann kyphosis patient to the AIS patient, they have worse self-image scores, pain, mental health. All the domains are diminished compared to AIS, and they improve to a greater extent as a result of that with surgery. So they do very well. This guy is a rower. He doesn't mind the way his back looks. It bothers mom more than it does him. And if he's going to go on to row in college, you did, I think. You rowed
a little bit.
Rowed Scholar.
Yeah.
And it doesn't bother him. So I think you could hurt his career if you've got the sagittal stable vertebra is L3 in this case. So I would try to encourage him to hold off, and you could always have it done later if it does bother him. And when Stephen was presenting the case earlier on his case, I was thinking an anterior shorter construct might be something to consider, addressing the apical segments, as Bob Gaines does on his stretch films. Yeah. You could consider an anterior only construct with dual rod instrumentation, so you could do something shorter, but I'd definitely try to leave this kid alone.
It's interesting, that idea of an anterior approach. Bob Gaines used to talk about bone on bone. I never really understood that because to some extent, anterior surgery can be so kyphogenic. So is it really bone on bone, or you're putting in interbody implants?
No, I think in this case, you would have to do interbodies with little mesh cages or something, small mesh cages at 4 or 5 segments and dual rod instrumentation. I've done it on a couple cases and they've worked out.
Yeah, so I like the idea of maybe going shorter here. We can maybe do a 4-level construct, maybe 3 interbodies across the apex, and maybe preserve some of that mobility as opposed to going down to L3, right? Who else might have some thoughts about, Barry, you talked about the fact that doing surgery young, he'll recover quicker. You said we can wait into adulthood. And what's the downside there of waiting into adulthood and seeing, if this becomes symptomatic? If it becomes symptomatic, I'm going to guess maybe it's going to become symptomatic when he's in his 60s. And I'll bet when he's in his 60s, we'll be doing things very differently than we do now, right?
So I think at the minimum, following these patients and letting them know sort of the natural history so they can make an informed choice is the important part. But I agree. I would leave this alone because he's not bothered by it. He doesn't have pain yet. I think the chance that he will have pain is high. But also with type 2 Scheuermann's, you can probably get a reasonable correction bracing. So I would try bracing for him.
Yeah. He's having 17 now. You still think about a brace maybe?
Probably still thinking about a brace, yeah.
And you say that it probably will become symptomatic. Chris, maybe I'll refer this one to you. He's 17 years old. His mom says, I've got terrible back pain, and I'm worried about him having disabling pain when he gets older. Do you see many adults with a thoracic developmental kyphosis who are symptomatic as adults?
Well, I'm going to tell you, I probably operated on 15 Scheuermann's kyphosis cases in late adolescence, early adulthood. They all had around 90-degree curve, something similar to that. And I'm going to tell you, all of them end up doing a traditional surgery to L2 or L3. All of them end up with some lower back pain, all of them out long enough. So I really have a concern. If he says I'm happy with things, there is no way I'm gonna touch him. And usually the mother said, well, what happens in 3 years when he's off our insurance, or what happens, or he may not care what he looks like now, but he gets into college and there. The fact is, though, is that between 17 and 25, the amount of correction you're going to get is probably not going to change particularly much. And I think that this operation, if you're doing it now, is cosmetic. And is it really worth that risk to him, for really a cosmetic operation? So, so if somebody came in and said, look, I'm in terrible pain, they could eventually convince me. But for him saying, look, I'm doing okay, and I would agree with Baron, usually something like this, I usually have, one of my assistants knock on the door and ask Mom, it's about some question about something. And when Mom's out the door, I say, look, is this something that is really bothering you? And then you can usually do some type of, kind of advanced physical therapy. There's other things that you can do to try to work on this. But now, if you change it around, and he came in and said, look, I am really unhappy with the way my back looks, and I'm really self-conscious about it, whatnot. I certainly could be convinced to do it. And usually what's going to happen is, I think the kids, they know if they're going to get their brace off, that they stand a little straighter and their scoliosis is a couple degrees better. I think that these kids, if they really want surgery, they come back for another x-ray 4 months or 6 months later, and they're slumped over more, and it's gone from 85 to 90. And you kind of say, okay, it's progressed 5 more degrees despite you being 17, and do it. If I was going to do it, I don't think I would do a short segment when I would do kind of a classic T2 to L2 or L3, let me see, 5, 4, 3. I think you probably could stop at 2. I'm just looking to see if the 1-2 disc is lordotic. But you could probably maybe stop at L2. And I just do Pontes in the back and get him corrected to 55 degrees, and he'd be happy.
So all these cases are going to be controversial. So to that end, we'll do a little vote now. And so we've heard a couple spectrum things. Who wants to do a short anterior, preserve some motion, maybe just get the apical 3 discs and 4-level fusion anterior only? Okay. Who wants to do something posteriorly? Chris pointed out a lot of subtleties very quickly, but he talked about the vertebra that's touched by the posterior sacral line, which I agree is probably L2. And he also want to know, hey, is that 2-3 disc, is that lordotic or kyphotic in that 2-3 disc? So who wants to go down to L2, maybe T3 to L2? Go posterior. And who wants to say, you know what, let's see how this is going, get through your collegiate rowing career, and if this is symptomatic, we'll do something down the road because we're not burning any time. Who wants to watch this? Okay. So, and most people. So it's interesting because I think in a positive meeting, he'd have a lot more surgery. But having said that, this was an interesting case in that his high school rowing coach is a colleague of mine. So this got into me talking about the ergometer and rowing technique, and we did a lot of non-operative things. And Baron, I think I've got your article in here somewhere on a longer talk on Sherman's. But knowing the natural history, this is out of Iowa, and understanding that when curves got to be more than 100 degrees, maybe some PFT troubles. But the natural history in general was pretty benign in most of these patients in Iowa. So what are the potential future consequences? Rare neural dysfunction, pain can be quite variable. The self-image part, well, in Iowa, they were more frequently unmarried. So that was interesting. But this is a slide from my partner, Mohammed, who talks about the self-image. This is a Shakespeare quote. This is the Duke of Gloucester and Henry VI, who says, to make an envious mountain on my back where sits deformity that mocks my body. Right? So self-image is a big part of what we see in this. But I always refer to these fellows here. I don't know if anybody remembers 1976. I was a kid at the time, and Mark Spitz won, I think it was 6 Olympic golds. Was it? Okay, there you go. Mark Spitz, there's a swimmer. And only to be bypassed by Thorpe, wasn't it? So subsequently, so this was 1976. He's on a cover of Time, and he's probably on a cover of Wheaties too. And he had a 90-degree kyphosis. And some people said that's why he was so good at the butterfly, is because he can get his arms around. And I'll just tell you a brief story. Can you go ahead and start the clock? Because otherwise I'll talk all day. Just so I get an idea how long I'm going. And so Mark Spitz, in 92, he and I were both trialing for the Summer Olympics, and Mark Spitz is there, and he was at the time in his, ancient. He was at least 40. He must have been probably older than that. He was, at least in his 40s, and he was ancient, and he just missed out on a trial. I think he finished third in the final, so did not make the '92 Olympics. But shortly thereafter, I became an orthopedic resident, and we were taking care of a kid with an 85-degree curve. And John Hall, again, my mentor, and the kid's totally asymptomatic. And John Hall says, well, he'll be disabled as an adult. And I told him the Mark Spitz story. He said, yeah, well, Mark Spitz, I'm sure now he's disabled. And in fact, as an ancient 40-year-old, he was actually still trialing for the Olympics. This is Hunter Pence, who's in San Francisco, a very famous baseball player, or was a famous baseball player. He has about a 90-degree kyphosis and plays professional baseball. And I put this one in here for Shane. This is I don't actually know much about hockey, but here's somebody from the Bruins who said, it was never really an issue for me growing up. The only reason I really noticed it was people kept on telling me to stand up straight because I was bent over, and it didn't affect him. And this guy was actually a very famous brawler. He was, in hockey, you got these guys, again, we need Shane here to explain this, but you got these guys who come in just to fight. And this guy was a fighter for the Bruins. So anyway, I ended up I ended up operating on him, in part pressure from his mom, and in part he felt that he had some limitations. He did go on to row through high school after this, competed as a freshman in college, and I was actually quite interested in whether or not that affected his rowing. And he said that that's not why he stopped rowing. He said he was actually still quite flexible and able to row. But having said that, it would be interesting to have a more objective assessment of this. So I ended up fusing them from, my typical construct is I tend to get to my UIV, I'm trying to get into a lordotic segment, so I don't want to stop at a kyphotic level. So typically that's at least T3, if not T2. In this case, I put screws at the top. I typically put hooks at the top. And then I stopped, as Chris suggested, at L2, which was that vertebra that was the one touched by the posterior sacral line. And that's what he looked like postoperatively. Now, what about when it goes wrong? So here's a guy who actually had surgery about 20 years ago. This is when he was an adolescent, had 5 surgeries for Sherman's kyphosis. And you can see here when I met him, basically he had multiple infections and non-unions. So somebody decided to just cut out the apical segments. So he had a miserable experience. This guy actually is a very famous person. He writes the For Dummies books, all the computers for dummies. He's a very accomplished guy, but he's certainly unhappy that he ever had surgery on his spine. And in part, I think the problem with this is that you're trying to get something to fuse in a kyphotic posture and with some older instrumentation without segmental instrumentation. Obviously, he had troubles. I ended up revising this to this. So, we got him in better alignment, and he actually was functioning quite a bit better. At this point, he was in his 30s when I operated on him. But I think this is just an example of it's not as if nothing can go wrong, right? So this is an example of somebody who probably wished he had never had surgery in the first place. He's fused down to L4, and Barry's already told us that even in a 30-year-old, certainly in a younger person, the natural history of 4-to-1 is not great. All right, how about another example? It is more straightforward one. Maybe this is for the fellows here. And anybody recognize what the deformity is here? Where's that, Zach, sitting there? No, who's here? Where's Zach? Graph it every. Oh, there, that is you. Zach, what do you think's going on here? This is a 16-year-old boy, standing films. In this case, he was braced before I met him. I probably wouldn't have used a brace, but what do you think's going on here? I might have some better films coming up.
We have a PA lateral scoliosis films. Thank you, Dr. Metz. We have a PA and lateral or AP and lateral scoliosis films outside of a brace. We have a left-sided thoracolumbar curve and a small right-sided proximal thoracic curve. Looks like he has a pretty sharp fractional curve at the lumbosacral junction there.
Yes, that's what you really recognize. And it's the driver here is that lumbar sacral junction, right? So you kind of think about what's structural and what's non-structural. And I don't think I'm going to give you any bending films, but I do think I'm going to give you. No, I'm not going to give you even that. Okay. This was meant to just be a short one. This is a patient who's got a lumbar sacral hemivertebra. And we know from McMaster's work that those probably got the worst natural history. And so this is one that's going to progress. You can see here that congenital anomaly at the lumbar sacral junction is driving that thoracolumbar curve. So this is something, if we leave this alone, he's developing a very much a structural curve in that thoracolumbar spine. And in my hands, by fixing this, and I did a posterior-based hemivertebral resection, but by fixing this, kind of trying to get that L4 as close as possible to horizontal, I think we actually dramatically improve the natural history of that thoracolumbar curve. And this is somebody who I've done some time ago. I followed him through high school, and he was actually, of all things, we don't see much of this in Northern California, but he was a hockey player and went on to play club level college hockey, but competed at a reasonable level and never acquired any adjacent level problems. So certainly our congenital scoliosis cases are ones, and I won't belabor this one because I think that Javedan did a nice job of showing one of these earlier, but this is another congenital case. This actually came to me from Washington, D.C., a child who was casted as a four-year-old, had progression of deformity, and this is a type 1 congenital kyphosis. The natural history of this is really quite bad. He presented to me at age 4 having lost some developmental milestones. So he went from being continent to having a lot of trouble with enuresis, having trouble with gait, some ataxia to his gait. And so again, he's already been braced. He's got a progressive neurologic deficit with compression on the conus. Rafi, do you want to talk about what you might do here?
Yeah, we kind of already talked about it. His major complaint was the neurologic symptoms, or?
Yeah, his major trouble is he's losing his milestones, right? So he's 4 years old and he's losing his bladder continence and ataxic in his gait.
Yeah, I think the most important thing is to decompress the conus at that level, and because it's so kyphotic, I think you have to resect, do a VCR at that level.
Yeah, so he actually initially had surgery, and the thought here was, gosh, he's young, he's got a lot of growth remaining. So he was treated with an in situ fusion with the thought that he'll grow out of this. And I think that's probably not a great approach. And in fact, he developed, after that surgery, progressive neurologic troubles. And Tim Resko and Youngjo Kim wrote about this and basically said that in these type 1 deformities, the natural history of this is really quite poor. They did say that before age 3, which I don't know what you think about this, Baron, but before age 3, maybe trying to do something posteriorly only, maybe for type 2 and type 3 deformities, but in type 1, probably being a little more aggressive about this.
I agree. I mean, you don't want to operate on them before age 1, but sometimes they're progressive. So age 2, 3, it's progressive deformity, particularly with neurological involvement. One choice,
So recognizing the point being recognizing the disorders in the pediatric population that have a negative natural history and treating those relatively aggressively. So I did a posterior-based vertebral column resection on this, put a cage in front, corrected him over the top. And this was back in 2016. The original surgery was in 2013. We got a 3-year follow-up here when he was 8 years old. And at that point, he was actually quite active in all things in equestrian and hockey. And he went on, I've seen him subsequently. He's in high school now, and he's actually kind of this ornery high school student, but his parents are very appreciative. He doesn't really remember much of the whole ordeal, and he's kind of an ornery kid, but he still comes back. He's going to see me before he goes off to college. All right, so, and that's his correction. So again, understanding natural history becomes really important here. Now, what about this case? Let's move into scoliosis cases. 17-year-old girl. She is high school in the San Francisco area, actually. No pain or limitations, and she's got a scholarship to USC to run the 400-meter hurdles. So she's got a 3CN curve, and one of our partners, Mohammed Diab, always cringes when I use the Lanky classification. So sometimes I just say she's got a structural thoracolumbar, or thoracic and a structural thoracolumbar curve. And in this case, I think the thoracic curve is a little larger than the thoracolumbar. So that's how I might characterize this. And who are the other trainees that are here? I don't recognize everybody. Any other trainees in the room, or any? Because we tend to beat up on a trainee. This is a hard one here. What's that? All right, yeah, that counts as trainees, right? Yeah. One of you guys want to step up and talk about what are your thoughts about this deformity and what you? I'm gonna.
Sure.
What to do becomes more controversial.
17-year-old female, scholarship to run the hurdles, so no pain, asymptomatic, but AP scoliosis films, I'd guesstimate that at about, 50 degrees. Oh, it says right there, 52. Yeah. Okay, 34. Well, my understanding is 25 degrees and less, you can observe it. She's asymptomatic, but 52, I would think that's probably likely to progress if nothing gets done. I'd probably counsel her that way and offer her surgery, but at the same time, asymptomatic, about to go run hurdles, maybe observe it for a few years before we do something.
That sounds good. So who wants to, Barry, what's the chances if we fuse her thoracic curve? I'm tempted to do that because I'm going to tell you that she bends out. When she bends left, I didn't have the bending films in there. When she bends left, that thoracolumbar curve bends out to 20 degrees, okay? So I might say, hey, if I operate now, I could prevent that lumbar curve, the thoracolumbar curve, from becoming structural, right? So we're pushed on that a little bit. At the same time, I'm not sure if she's going to be running 400-meter hurdles. So what are your thoughts? This to me becomes a difficult one, right? We got to. I'm going to say that I should probably call this. Let me call this a 1C curve for now, rather than calling it a 3C, because I can tell you that thoracal. I'll change the scenario. The thoracolumbar curve bends out to 20 degrees.
Yeah, I agree. I think it's a 1C. Again, I think it comes down in the old days. 45-degree curve or more, boom, surgery. Now we talk to the families and get a sense of the priorities. And I would let her do her college career first, and then she'll be back. Now, sometimes they say it doesn't bother me much, but then as you get to know them, it does bother her. There's a big rib deformity, rib prominence. She's tired of people commenting about it, or she has some pain. But I'd lay it all out. I think there is some value to fusing early to prevent the lumbar deterioration. So now versus later, that paper that we had, we looked at this. So I think there is value to it, but I would have no hesitation to delay till after college.
Okay, so you're not concerned that lumbar curve might become more structural at this point? I
don't think so. I think she's mature at this point. I don't think it's going anywhere. But I also have I have a patient, years ago I gave a talk, it was an all-hook construct in a young guy with a 55, 60-degree curve, and I did a selective thoracic fusion, and he had record times in the 400-meter hurdles. I don't know if it was in the 40s, 40 some odd seconds to do the 400-meter hurdle. So, but after a selective thoracic fusion, so it's possible.
It's probably in the 50s. I think
probably the 50s.
Edwin Moses
is
still.
40s is too fast. But it's possible to have a career. So I would leave it with the patient.
Okay. So, a couple of things about this that I think is interesting when we really look at, again, I think you referred to this already, better curve correction in younger people, maybe some lower risk of junctional problems. So doing surgery early might make sense. So in her case, she actually did go on to run at USC. And interestingly, as a junior, and she was doing well. She was one of the best at the high school level. At the college level, she wasn't that outstanding. And as a junior, she made the decision. She said, "Hey, this is really starting to bother me, and I don't want to run hurdles anymore." And so we ended up doing a selective thoracic fusion. Actually went to L1 in this case. You see, got some pretty nice resolution of that lumbar curve. And I think maybe by doing this, avoided that lumbar curve from becoming structural. And she ended up, of all things, sort of interesting. She was a very good hurdler. As a junior, just stopped running completely. And then she got into modeling and photography and stuff, but completely stopped sports. So I don't know how her running changed. I always like to ask this question of how did this affect your sport, be it rowing or running? And she said she just doesn't run at all anymore. So, but I don't think it's because of her spine. I think it's just lack of interest. How about one that's maybe a little more controversial? And I think this probably truly is a 3C curve, right, if you agree. Again, double major curve, structural thoracic, structural lumbar. And this girl is only 11, right? So the last one was 17, was scoliosis mature. So this girl, I can tell you, is Saunders 3. She's premenarchal, 11 years old, and she's got a 3C curve. Who wants to? This to me is kind of a challenging one. I don't know if everybody else agrees or if it's obvious to everybody. But Zach, what are your thoughts? Since you're volunteering.
I think we have a skeletally premature female who's approaching her. She's already passed her peak growth velocity, but she still has considerable growth left, and I'm hesitant to fuse her so young, knowing that she has so much growth left. Considering the amount of growth left, but her two large structural curves and their high likelihood of having significant progression, I'm going to plan for a fusion surgery and see how long I can hold that off for. I would hope that the lumbar curve, although structural at 68 degrees on a standing film, and I'm sure it bends out to some degree, not less than 25, but to some degree, I think I consider a brace to get her a year or two more time and try to do high compliance bracing activity for a year or two. I'm not necessarily a believer that the physical therapy for scoliosis has demonstrated great outcomes, but I try to give her some activities to complete with physical therapists, with bracing, push this off a year or two without significant progression, and then fuse her once she's slightly more skeletally mature and see if I can gain some time for her.
Yeah, so she's been in a brace for a couple of years, has progressed in a brace, but I certainly like the idea of bracing somebody who's still got some growth remaining.
If that's not so much an option, I then would consider either a growing rod construct until I can get her to a final fusion, or like a sliding construct that needs to go back for a little bit until I can get her to a final fusion. But I don't want to give her a final fusion construct at this time while she has so much growth remaining.
Barry, how old's too old for a growing rod?
Yeah, I think she's a little too old for that approach because there's a lot of morbidity to that. Her triradiate cartilages are closed. She's premenarchal. Yeah.
Premenarchal, yeah. She's I said Saunders 3,
yeah,
but still premenarchal. Yeah.
Saunders 3. So she's kind of within early stages, within or toward the end of her growth spurt, with closed triradiate. So I think she's got most of her adult height. And if you do a definitive operation now, she's not really going to lose much. You can do the calculations of 0.07 centimeters per segment on average per year of remaining growth. And I don't think she's going to lose very much, and she'll gain a couple of inches in height if you do something definitive. Personally, I'm on a crusade to save the lumbar spine. So I probably, you want me to say what I would do?
Yeah.
Okay.
Yeah.
So I would probably do a hybrid here. I would fuse T3 to T12. And then I would do a same day tether below to L4, T12 to L4.
So have her prone, do T3 to T12.
And then
How do you decide how much correction that you really want to get there, because you kind of got to balance these curves now, right? Her shoulders are a little elevated on the right side preoperatively, but her trunk's not shifted. So how do you predict how much you can get out of that lumbar curve to keep them balanced?
Yeah, we do the benders first. I think the lumbar is going to be pretty flexible. You could cheat a little bit into the lumbar spine with the fusion, so even go into L1, just make sure to derotate that segment, which is going into the other curve. So if you grabbed L1, I think you're going to get that proximal part of the curve very straight, and then tether below. So I would look at the benders and study it, but if it's relatively flexible, I would just go to fusion to 12, tether below, or fusion to L1 and tether below that.
It's funny, I was going to say a hybrid. I would have done anterior and probably going to do a fusion, so I can definitely stop at L3. I think that whether you stop at L3 or L4, do traditional, but I usually, if I take the discs out one, that I can definitely stop at L3.
Yeah.
So I would do the lumbar curve where I would fuse it, not tether it. To that, and then I do believe in stopping in the fuse as little of the lumbar spine. I agree with Baron as much as possible. But usually, most people who have a fusion stopping at L3, they do pretty well in adulthood. Okay, so I would do the anterior approach and then extend up posteriorly, very similar to what Baron had described.
Yeah, I like that. And, Baron, I think your graph showed that there's a big difference between 3 and 4 in terms of the natural history, right? So stopping at 3 really does make a difference, doesn't it?
It makes a difference. That's only 10 years in a long life, so, we'll have to accrue the data over time. And the other thing is, I think Chris is right, the anterior approach will help you get a good correction and maybe save a level. But, the cob end vertebra here is L4. If you leave L3 as the LIV translated, then the rate is a third of the patients at 10 years will have significant disc degeneration. So it's imperative that the LIV gets centered. I think you probably could do it.
I was going to ask you, I think, at least for me, I can do that better from the front. I'm not as predictable. And if I was going to do it from behind, I'd probably stop at L4 at the cob end.
Yeah, I agree, Chris.
Yeah, I think that's the 5C curves are a really good example of that, where I think you could almost always save a level, anterior versus posterior, at least one level. Yeah,
I think I would just opt to do a selective thoracic and talk to them about potentially tethering the lumbar curve down the road. So sort of similar approach to Baron, but in a staged fashion.
Yeah,
and I think the other thing, you showed this nicely on your last case, Sig, is we have this dogma about not going into the next curve, going into the lower curve. But I do think, what you showed on that last case going down to L1, which was into the next curve, actually helped the spontaneous correction quite a bit.
Yeah.
So I don't know that dogma is the right dogma anymore now that we're getting more aggressive corrections. I don't know, Baron, what you think about that? About going into the next curve.
Yeah. As opposed to hitting a home run with that, getting it as straight as possible and going into the next curve?
Yeah, exactly.
Yeah.
Where to stop.
Yeah.
Where to select your LIV.
Yeah. Typically I would go to the stable, which, the upper stable, which should be 12, I think. But, Peter Newton talks about this a lot. I think he tends to go one level below that. So I think, that probably would help you with it a bit.
All right, so here's our choices. An 11-year-old, we're going to brace her a little longer and wait till she hits her puberty, or wait till she's, Sanders 4 or 5 and get a little growth. Wait till she's 13 or 14. Who wants to observe this, maybe brace her a little longer? Okay, so Sergy now, who likes the idea of a hybrid, or who likes the idea of selective thoracic? So do T3 to T12 L1, and then maybe address that what is already a structural lumbar curve, but we'll address that structural curve down the road. Okay. Who likes the idea of going ahead and doing a hybrid, fuse the thoracic, and tether the thoracolumbar curve? least some mobility. And how about a double fusion, posterior for thoracic, anterior for thoracolumbar? Because we got that one. So the diversity here is really quite dramatic. And who wants to just go ahead and do the most definitive, least likely for revision, T3 to L4, neutral stable to neutral stable? All right. Well, that's what I ended up doing. And, it's still a little bit of, did I stop at 4 there? I think I stopped at 3 there. And I think I might have done a better job had I stopped at 4. But so far that this is holding out pretty well. And this is probably at least 6 years out. Stopping at L3. But I do agree. I think I probably could have gotten a better correction. I stopped at L4. But again, going L4 to me is a real problem in the young child. So now here's another example of and I bring this up as an example of in this case this is again a double major curve, but in this case I'm going to say it's more of a 6 cm, meaning that thoracolumbar curve is bigger than the thoracic curve. And I can tell you that at this point, this woman's 36 years old. She's actually works as lab tech at UCSF, has 2 girls. This is now getting to this idea of transition. I know that Lionel's going to give me a cut sign soon, so I do want to at least get through this one. So this is the idea of a transition. So she's somebody who's told, hey, you ought to have a fusion T3 to L4 when she was 16, and she and her mom chose not to. She's been very active, actually plays club level volleyball, has two young girls, ages 3 and 5. Again, diagnosed at age 12, braced, told at age 16 he needed a fusion down to L4, and she'd been very active until the last 2 years. In the last 2 years, her real symptoms are that she's got left leg pain. So left, really L5 radicular pain, okay? I think I'll show you a few more images on this one. So these are just her standing films again. Oh, geez, I did these more for rapid fire. So she's told, she's 36 years old now, and she's told, I thought I had some bending films in the MRI on there, but basically she's got some concave stenosis at 4.5 and 5.1, had some selective nerve root blocks, got better. And so she's told, seen 3 different surgeons now, and was told by 2 of them, you need to be fused from T3 down to the pelvis now. You know, in adults, we don't stop at L4. So she kind of went in there saying, hey, can you still do that surgery that was recommended when I was 16? And they said, no, you know, now we got to go down to the pelvis. So we're going to do the whole thing. And so who likes the idea of fusing her down to the pelvis? T3, volleyball player, 36 years old. And so anyway, you saw so I ended up just taking care of that.
I would just say, if you have L4 radiculopathy, because you see where it's really switched down at L4, if it was just an L4, I would go to an L4/5 kilo anytime. The only thing is that your results, this is what I tell people, I told you, what you did, I tell people there's a 50% chance in 5 years you're going to have some kind of breakdown requiring to have an extension proximal. I think what you did is it looks really good, and you know, you set her up nicely to if you have to do an extension proximally, make that easier. You probably don't have to really extrude it now that she's solidly fused at the bottom, et cetera, et cetera. So I think it's a beautiful result.
This ends up being, my hands are front and back, because you get that fractional curve, that ends up being really stiff. I didn't show you the bendings, but that fractional curve, and you do a nice job with the T-lift. To me, I like doing front and back, firstly to get that good lordosis from 4 to 1. And everybody,
I might handle it a little differently, especially some of them will have lumbar convex pain. She has radiculopathy at L5 level. I would consider doing an anterior fusion. I showed a case like this morning, T12 to L4. The fractional curve will level, and a lot of times the leg pain gets better. Okay. So I might do that.
Yeah, so that
and leave the thoracic alone.
If you pull the L4 up a little bit, you know, actually open up that 4-5, yeah. You know, she's trunk shifted a little bit towards the left, and so she definitely wants to be, you know, and if you bring her more to the left, she might compensate and actually open up that 4-5 on the left side.
I mean, it depends also, say, of course, what the disc looks like at L4-5. It's not healthy, and it's But a lot of times it's just the nucleus is pushed over and it's a reasonably good-looking disc, but it's a radiculopathy because of the fractional curve. I would do what I said.
Yeah, it's an interesting opposite approach because, in the adult, we're so often thinking about going to the sacrum, and you're so often thinking, you said earlier, you haven't been in sacrum for a long time.
Yeah.
And I just put this one in here. This is my partner, Dr. Diab, and so being along the lines of what Barry's talked about earlier, so a double tether is could have been something I could have avoided or could have improved the natural history on that. I think I've got a couple of syndromic cases after that, but I think at this point.
We have some more tomorrow, so we'll take them for tomorrow.
All right. So yeah, but broad spectrum of things to do with the adolescent, and thanks for that interactive participation.